We have 199. Good afternoon, everyone. Welcome to this webinar on point-of-care intestinal ultrasound, presented by Dr. Carrie Novak. Today's webinar will cover assessments of bowel ultrasound by explaining techniques, showing ultrasound cases of inflammatory bowel disease, and discussing alternate diagnoses. The AIUM is accredited by the ACCME. This webinar is designated for 1 AMA PRA Category 1 credit. By the conclusion of this webinar, participants will be able to understand intestinal ultrasound by knowing the technique and features of a normal, large and small bowel, recognize features of inflammation and complications seen in inflammatory bowel disease, and review alternate diagnoses to this disease. As an ACCME accredited provider, it is the AIUM's policy to ensure that the content and quality of this activity are balanced, independent, objective, and scientifically rigorous. At the conclusion of the webinar, you will be able to access the CME test located on the AIUM website. For more information on accessing the CME test and claiming credit, please refer to the handout provided in the dashboard on the right side of your screen. Participants who complete the post-test with a grade of 70% or higher will be awarded 1 CME credit. All individuals who are in a position to control the content of an educational activity are required to complete a disclosure form. All disclosures are reviewed by the AIUM, and any conflicts of interest are resolved or managed prior to an activity. Dr. Carrie Novak and Darcy Belito de Luna have no relevant disclosures. Credits for this webinar are approved for physicians, sonographers, and radiologic technologists. During today's presentation, if you have questions for the presenter, you may type them into the question box on the right side of your screen. You will be able to submit questions throughout this webinar, but the presenter will not begin answering until the end of the presentation, at which time she will answer as many questions as possible. A recording of this webinar will be available on the AIUM website. And now I'm pleased to present Dr. Carrie Novak.
Good afternoon, and thank you all for joining me.
There we go.
In the middle of your busy days. Darcy, can you hear me okay?
I can hear you. Sound very good.
Wonderful. Okay, so welcome again. I'm excited to present to you my love, which is an intestinal ultrasound. I'm a gastroenterologist. I work in Calgary. I work in a dedicated inflammatory bowel disease clinic, but we see a range of diseases, and we have a very close collaboration with radiology. So Darcy has very nicely gone through the objectives, so I won't go through those again. But I want to start with this lovely image of one of my patients, Bree, who obviously, and to be quite clear, all the images you see in this presentation, all the cases, all the endoscopy images, the patients have consented to participate in this presentation with their consent. So this young lady, Bree, is an engineer. She's 23 years old. And she has been my patient since she's been about 21. Prior to, she came from a smaller town in British Columbia, the province right beside us. And she tells me that when she was diagnosed at age 17 with ileocolonic Crohn's disease, by the time she was 20, she'd had 5 colonoscopies. And these are tough for her. They caused a lot of anxiety. And she really, because she was sedated, didn't understand why they were happening or what the findings were. So I think Bree is an excellent example of somebody who's really engaged in ultrasound when it's performed in clinic for her to stage and grade her inflammatory bowel disease, because she can see and learn about why we're making the decisions together we're making and understand where and how active her disease is. So the challenge, as many of you know listening to this, with gastrointestinal disease or absence of disease is that they present very similarly. If you took 5 patients with different disorders, Crohn's disease, irritable bowel syndrome, functional dyspepsia, even colon cancer, they may all present with very similar concerns: fatigue, bloating, nausea, abdominal pain. These and various other concerns make it challenging to understand what is going on because the gut is hidden. So we can do blood tests like C-reactive protein, and you can see an image here of a small well for an ELISA, a test we routinely do in gastroenterology called a fecal calprotectin that detects a protein produced by inflammatory cells. And then imaging is increasingly a component, but there's some concerns and limitations with some of the available imaging that we have at our disposal, particularly in the emergency department where lots of patients undergo CT scans. And we're increasingly aware, particularly in our inflammatory bowel disease patients, of ionizing radiation exposure. And we're all worried when patients present with different symptoms of bad things going on in their gut. So you can see on the right-hand pane, active ulcerative colitis. On the left, deep serpiginous ulcers consistent with Crohn's disease. And then the worst case scenario is when someone would have a malignancy and they present newly with symptoms. Now, the way in which we make these diagnoses is by colonoscopy, and it's a tough test. I don't know how many of you have had 4 lovely liters of colate to drink, and the colon doesn't always look quite as clean as this, so it's a challenging test. So we don't, take colonoscopy lightly, and this is a cartoon to poke fun at this a bit. Frank, you don't need a colonoscopy, but I'm sending you one because, frankly, I don't like you. So colonoscopies are a tough gig, and they don't always reveal the area that we want to see. So this is a beautiful depiction of the cecum using, in the very center, you'll see the appendiceal orifice where the appendix comes off, and the circle in the right lower quadrant, or the right base, is the ileocecal valve. And so the small bowel for gastroenterologists and for many of us, even endoscopists, is blind because we can only see maybe at most 20 centimeters of terminal ileum. So it's a difficult area to reach, and so you have to do more complex double balloon or deep bowel enteroscopy to adequately visualize it. So the terminal ileum is actually very terminal, is all we can see. So why would we do imaging, particularly point of care ultrasound, when we use it as gastroenterologists in clinic, and why you would use it in the emergency department or in an internal medicine clinic? Well, there's 4 main benefits of evaluating a patient with intestinal ultrasound. First and foremost, you want to determine, is there inflammatory activity there? If there is, how can we determine where it's located? So we want to map the disease anatomically. We want to exclude disease that's higher up and characterize its transmural characters. For example, are the layers of the bowel normal? Is there damage to the bowel? So in Crohn's disease, this is a progressive inflammatory disorder. And as you well know, up to 30% of patients can present already with damage, which is characterized by narrowing, even penetrating complications, which are the result of holes in the bowel, fistulas, abscesses, even inflammatory masses or phlegmons. Thirdly, particularly in our inflammatory bowel disease clinic, we want to understand, is the medication we're using working? These are often expensive medications that do impart risk, so we want to understand whether they're working. And finally, one of the single most important elements of intestinal ultrasound, because it occurs in real time, is that you can see how the gut's moving, you can see how the gut's functioning. So importantly, when you're going to perform intestinal ultrasound, we are all familiar with the low frequency probe, the 5-1. This allows for deep penetration into the abdomen, and it's a brilliant probe and the first line probe for characterizing the rectum, which obviously is very deep within the pelvis. The higher frequency probe is great once you've mapped out and characterized disease, but the mid-higher range frequency probe is where we tend to start to characterize the bowel. So this doesn't always come on point of care devices, but this is a very important higher resolution probe that enables a good depiction of the bowel. Now, as an endoscopist, I tend to start in the left lower quadrant, as I would an endoscopic exam. But this is a personal choice that you make. Lots of folks, my radiology good friend Stephanie Wilson, she tends to start in the right upper quadrant where she can easily identify the hepatic flexure, and then she moves proximally. But if, like me, you start in the left lower quadrant, you anatomically define the left lower quadrant, and I'll show you some lovely ultrasound images. Then you move up to the descending colon, complete the transverse colon examination, ascending colon, ileocecal valve, small bowel. Here is how we depict that. So you can see here this rounded structure with striations. This is the psoas muscle. You can see above it here the rectus abdominis muscle, and this is the near field wall of the sigmoid colon, and this is the deep field wall of the sigmoid colon. And although there are 5 layers of the bowel, so the mucosa, the muscularis, and I will show you a picture of this, the muscularis mucosa, submucosa, muscularis propria, and the serosa, we tend to only see 3 prominent layers. So here you see basically dark, light, dark, and the very dark on the outside can be quite prominent in the sigmoid colon, and that's the muscularis propria. Here in axial depiction again, this beautiful white window in the center of the circle is poop. That's air-filled stool and its characteristic pattern. So often that's a bit distracting. So I have a lovely emergency room doctor training with me right now from Australia, and she said, you know, that's often where her eyes go, is to that bright stool pattern. And what's important is to take your eyes north and look for that smooth rim of bowel that can be very hard to see because it's so thin when it's normal, with that tri-layer pattern, those 3 colors. Here is the descending colon, and what characterizes the descending colon, in addition to the stool pattern that you're used to seeing now, is the haustra. So here we see the classic bumps of colon. That's healthy, normal colon without any evidence of diverticula. Again, very similar pattern in transverse. The orientation of the probe here is in transverse orientation. And as you can appreciate, it's very difficult to see those 3 layers. Here is the inner layer, here is the submucosa, and this tiny little black line is the muscularis propria and the classic stool pattern on the inside. Once you have evaluated the colon in its entirety, and obviously there will be modifications to this approach when a patient has had surgery, you then what we call lawnmower the abdomen with very careful appreciation of the right and the left upper quadrants to appreciate the small bowel, which tends to localize actually superiorly or cranially in the left upper quadrant and the right upper quadrant. Here you can appreciate beautiful long folds of the small bowel called valvulae connivantes. So these are not villi. Remember, villi are very small and they actually are not depicted. The villi increase the surface area and are on the valvulae connivantes. These folds are characterized in their length and are a pathognomonic feature of jejunum. In the ileum, you don't see the length of the valvulae connivantes, so you can actually not appreciate the folds nearly as much because of the length of those valvulae. Here is another depiction of the ileum, and you can see some of the folds a little bit better. And here is an axial depiction, and you've got both loops of small bowel with some contents. And one of the ways in which we characterize the wall is through color Doppler imaging, which I'll get to in a moment. Here is an example of healing in the small bowel, which is mostly normal. You can see one tiny little aptus also here. So the key here is to reflect the features of inflammation, which I'll go through systematically, and compare often to other examinations such as endoscopy. Now, as gastroenterologists performing intestinal ultrasound, can we actually see things that other imaging modalities or endoscopy sees? Well, absolutely. So The accuracy data is growing and certainly becoming more and more robust, but importantly to date, there are approximately 5 meta-analyses that demonstrate very well high sensitivity and specificity of ultrasound compared to variable modalities. And I say it's heterogeneous because the gold standard is quite variable. So the gold standards include CT, MR, and endoscopy. And you can understand there's some challenges when you compare something like endoscopy, where the actual imaging is only of the inner lining, compared to something like a CT scan where you see a much more global depiction. Regardless, ultrasound is very accurate for the detection of inflammation, complications, and postoperative recurrence. Now, here is a heuristic to help you understand what you're seeing when we position the probe on the abdominal wall, what those layers look like. So I mentioned the 5 layers previous. Keeping in mind the mucosal layer at the lumen, in the lumen, so the luminal margin, and the outside, so the mesenteric edge of the serosa, they're both 1 cell layer thick. So they're actually just a reflection of sound waves, and they're both bright. But they're so thin that you have to be careful when you're measuring the bowel wall thickness, which is a very important parameter of inflammation, that you don't capture too much of that reflection. So what we see on sonography is really these 3 stripes: the thicker muscularis propria coming from the serosal side to the lumen side, the whiter or echogenic layer of the submucosa, and then the muscularis mucosae, which again is a muscle layer and thus hypoechoic. Here are my labels, as you can see. Here is an example of transverse colon in transverse probe orientation to try to highlight these layers that we see. So using my small arrow here, this is the serosal margin, and this, you can see, is this bright reflection of serosa. Then we come in to the first outer layer. We'll start with the lumen side. So the lumen is actually collapsed here. This is thick bowel. This is sick bowel. Actually, this fellow has Crohn's disease. And so the lumen and the reflection of the mucosal lining is actually not well demonstrated. So the first line we see actually is the muscularis mucosa, then the more hyperechoic layer, which is the submucosa, and then as we approach the serosal margin, the muscularis propria. Now, we've talked quite a bit about the normal layers. We've talked about the different segments of the large and the small bowel. How do we determine if there's inflammatory activity? Well, let's go through it step by step. The single most important parameter that best predicts inflammatory activity is bowel wall thickness. So this is a markedly different image than the previous ileal images that you have seen in this presentation. NTI, and this acronym stands for NEO, or new terminal ileum. This is a postoperative Crohn's patient who has recurrence in the distal terminal ileum that we call NEO because the more distal segment has been removed. So this is an axial image taken in the right lower quadrant of thickened small bowel. And as you can see, the 3 layers where the arrow demarcates, that bowel wall thickness is marked and approaches 1 centimeter. Normally, the threshold for pathology in the small bowel, we use a cutoff of 3 millimeters. This is a widely accepted standard. If you look at European guidelines like EFSAM, these are the standards for a cutoff for small bowel. The rest of the colon is similar. However, with age, we do see some thickening of the sigmoid colon, and that's primarily secondary to hypertrophy of the muscularis propria. So here in Calgary, both radiology and myself and my partner, we use 4 millimeters as a cutoff for the sigmoid colon, but there's some debate about that. As I've outlined, wall thickness is the strongest parameter predicting disease activity, and using 3 millimeters as a cutoff with very high sensitivity and specificity for the depiction of Crohn's disease. Here again is an axial depiction of how do we measure the bowel wall. So we come to the very inner margin of the lumen. So keeping in mind, this is obviously the lumen, and this is the muscularis mucosae. So this is this very white interface is where the mucosa is, and we go right to the very edge of that interface of the serosa, and we do 2 measures in axial, 2 measures in longitudinal, and then we make an average when we are formally evaluating a patient. Now that's a lot of work, and certainly it doesn't have to be quite robust depending on what your intent is. Again, this is how we measure the bowel wall in longitudinal dimension. These are beautiful images that are taken actually transvaginally in a woman by my colleague and good friend and radiologist, Dr. Stephanie Wilson. These are her images. This is, again, where the probe sits in the vagina. This is a longitudinal image of very thickened small bowel that lies deep in the pelvis. The second parameter after bowel wall thickness is color Doppler signal. Now, this is a way of looking at angiogenesis in the wall of the bowel. This depicts smaller caliber vessels than you might be used to picking up. And so it's very important that you set the parameters of the color Doppler to a lower speed. So we set those anywhere between 4 and 8 meters per second. Here is a video clip of again, the neoterminal ileum with a short capture of flow in that wall that correlates very well with inflammatory activity. And then we grade this semi-quantitatively using a Limburg score. There's a modified Limburg score we often use anywhere from 0 to 3, 0 to 4, depending on which score you use. So this clearly demonstrates lots of inflammatory activity and lots of color Doppler flow. We don't care if it's red or it's blue, we just care that it lights up. Now, here's an example, and I'll show you this case later on, of the third parameter, which is hyperechoic inflammatory mesenteric fat. So this little guy right here is actually the appendix, and this area down here is pus. This cap here is inflammatory mesenteric fat. And I picked this picture because it's so bright, and you can see this sort of cap around the appendix was actually chronically perforated. This was a long-standing perforation. And so this is an example of the third parameter that we look very carefully for, and is actually a pathognomonic feature of Crohn's disease. Here's another example where you can see this hyperechoic edge of this very dark hypoechoic bowel in axial depiction. This is small bowel. This little guy right here is a lymph node. So this is the mesenteric inflammatory fat. And that is the fourth parameter that we focus on. The fifth parameter is, or the fourth, there's how many parameters? I can't count. So the next parameter is a lymph node. And then finally, the last one is the preservation or absence of echostratification of the bowel. So you can see there are no layers that are distinguishable in this very sick, likely edematous and ulcerated small bowel. So there is an absence of normal echostratification in this bowel, which is a hallmark of more severe inflammatory disease in Crohn's disease. Bowel wall destruction, regardless, is a very important parameter to think of. And if you see a localized area of destruction, you must think of something progressive and something that's going to alter that structure. So a malignancy is certainly something that you think about. And again, I mentioned lymph nodes. So there are 5 parameters that we think about, and certainly there is an important caveat that sometimes it's a mix and it's not a slam dunk. So it's a subjective assessment of those 5 parameters and the relative degree of presence. So for example, in Crohn's disease, sometimes we see over lengthy periods of time ongoing thickening of the wall, but there's very little activity. So you might not see inflammatory fat, you might not see color Doppler signal, you might see preservation of the normal layers and no lymph nodes. So we suspect that there was previous history of inflammation, but it's currently inactive. Not quite normal, but inactive. So this is the way we assess bowel. Finally, one of the interesting things we do see, and here is again a beautiful depiction of hypertrophic mesentery inflammatory fat that's characteristic of Crohn's disease. This guy here is free fluid. So when patients are quite sick, certainly physiologically, as you all well know in the abdomen, you can see some degree of physiologic free fluid in very small amounts, but the greater amounts certainly make you think of a more significant burden of disease. And again, we would measure the bowel wall thickness again in axial, and I've already talked a little bit about the inflammatory fat that's present. So let's move on to some cases and apply some of these principles to these cases. So this is a young guy that was actually lost to follow-up, 27-year-old father who's a single father, lots on his plate, so understandably had missed some appointments. In inflammatory bowel disease, we always document whether they're smoking or not because it's such an important risk factor for progressive disease. He'd been on a powerful immune suppressant with the mechanism of, it's an anti-tumor necrosis factor and a monoclonal antibody. He developed some infections in his mouth, so it had to be stopped. He presented not doing well. He had active perianal disease, another characteristic feature of Crohn's disease. He'd lost a little bit of weight. And interestingly, he was having some pain and vomiting intermittently. But he was a minimalist, so he didn't complain a lot, and we didn't have a very good sense of how ill he was. He'd had an endoscopic examination with a prior surgery, so this is a little bit confusing, but this is sort of the blind end, and down here on the left part of the image was a stenosed or narrowed ulcerated outlet to the neoterminal ileum. So we scanned him in clinic, and as you can see, this is far up in his left upper quadrant. You can see just right away, this is very profoundly thickened small bowel. It is a halo of bright white around it, or echogenic mesenteric inflammatory fat. And really what we would describe here is an absence of preservation of echostratification. This guy right here in a still image, you can't tell whether it's a lymph node or a vessel. Obviously, when we can't tell, you can follow a vessel, as you well know, whereas a lymph node comes in and out of view. So this is possibly a lymph node, but we would have to further characterize that. Here we've got a couple of different images because this does a bit of a C loop, this loop, and you can see quite a bright suggestion of hyperemia or angiogenesis in the wall that again signifies active inflammation, again in more longitudinal format, coming in and actually some of the mesenteric vasculature feeding this vessel or feeding this loop of bowel. And then you can see here a C loop of this bowel that comes down, and actually we do document proximal dilatation. So there he exhibits all 5 parameters of active inflammation. He has a large C loop that we can characterize on a short video clip. And so absolutely he looks obstructed. He looks like he has severe disease. And we then completed the examination, and you can see in his right upper quadrant, this is again a loop of more proximal bowel, because you can see the valvulae conurbantes. This dilatation exceeds 3 centimeters, and you can see this abnormal peristalsis with to and fro contents that are non-propulsive, and this is significantly dilated, the threshold for that being 2.5 centimeters. So here we've got complications, we've got active disease, so he came into hospital. So it aided in clinical decision-making significantly. Because he had perianal disease, we further characterized this with MR, where we were able to evaluate the pelvis and demarcate the disease. And again, you can see this very significantly affected loop with thickened wall in T1 and T2 weighted series on MRE. So when we think about, so that's an example of a series of clear attributes that suggests profound inflammatory burden and activity. Let's move on to some complications, because these are really interesting things to identify in the abdomen. So Crohn's disease is characterized by progression, and one of the reasons patients go to the operating room, which is still happens not uncommonly, is because of the development of narrowing or stricturing. And characteristically, this happens often in the distal terminal ileum. It happens in all sorts of different places. You just saw an area in the jejunum, but this is commonly present there. Endoscopically, this is one of the main reasons why we can't complete examinations, because it precludes progression into the small bowel with the endoscope or the colonoscope. So here's an example of very ulcerated, narrowed, stenosed area that you can't actually enter with the colonoscope. So further characterization has to be done by imaging. The definition of strictures on imaging is variable, and the literature is growing, but we need to do some work. So both on CT, MR, and ultrasound, the definition comprises 3 elements: luminal apposition, bowel wall thickening, and proximal dilatation. Now, I would argue, certainly in my experience on ultrasound, that you can have stricturing that is earlier than later and not have proximal dilatation. And one of the greatest parts about evaluating on ultrasound is that you can actually see in real time that dynamic nature of the stricture. This is a still image, but I'm going to show you some images. So ultrasound, this is the same image I just showed you endoscopically. Ultrasound, there are a number of publications and actually 2 recent meta-analyses. Unfortunately, the quality is somewhat variable, and we really do need more studies evaluating the accuracy of ultrasound in detection of strictures. But this recent meta-analysis certainly argues for very high sensitivity and specificity for detection of strictures when compared to MR or CT. Out of interest, many of these studies come from Europe, and most of these are performed by gastroenterologists and non-radiologists. There's a mix. Often the studies from Spain, from the UK are radiologists, and from Germany and Italy are often gastroenterologists. So it's a really interesting and wonderful mix. Here's a surgical specimen of a stricture. Here's a real-time dynamic example of a stricture where you see to and fro peristalsis. This is non-propulsive. And what's interesting is you do see loss of the normal echostratification. This is very black wall here. And this is the area of stricture where you see this to and fro movement of contents. What's interesting and what has been shown histologically is this loss of echostratification is often secondary to growth of smooth muscle. So it's actually not just fibrosis, but hypertrophy of smooth muscle, and hence its hypoechoic characteristic. And this gentleman went on to have a surgery. Here you see this beautiful, not beautiful for him, but beautiful depiction of the hypertrophic mesenteric inflammatory fat and proximal dilatation, significant proximal dilatation in that stricture. Here is another example of a stricture where it's not quite so active. This is a terminal ileal loop that lies over the psoas muscle. You can see the psoas muscle here. We're following it, little bit of mesenteric fat behind it. That's probably more chronic. And down here, as we drop into the pelvis, you can see this normally peristalsing loop, so it's not dilated. So this is an earlier state, and this is an example where other modalities or adjunctive accessories to the ultrasound machine can be quite helpful in further characterizing this wall. So just like we look at liver stiffness, you can apply the same principle, ARFI, or acoustic radiation force impulse, to evaluate the elastic properties of that loop of bowel. So you put that region of interest on the thickened area of bowel, and you can then get a sense of how stiff that bowel wall is. Crohn's disease is complicated. Obviously, there's always a mix of fibrotic or smooth muscle hypertrophy tissue in addition to inflammation. And our question as clinicians is, how stiff is it? Can we treat this? Because we don't have any anti-fibrotic therapies. So this is just an example of another adjunct that can be applied in ultrasound assessment of abnormally strictured bowel. And again, this is shear wave elastography and shows a fairly good sensitivity and high specificity in early publications using this modality. Let's move on to another case. The second complication that we do see that we've just highlighted, another type of stricture. 38-year-old father of 4 had an operation in a town outside of our city, Calgary. And he presented after doing just phenomenally well after his resection, but 6 weeks later just had sort of sudden onset of bloating, pain, wasn't vomiting, didn't sound like he was overtly obstructed, and had been to see the surgeon. The surgeon said, you know what, this is just par for the course. Sometimes you have bumps in the road as far as post-operative courses go. Non-smoker, let's just watch. So he had some blood work done. He was mildly anemic, kind of fitting with a post-operative course. His C-reactive protein was not elevated, and at that time we weren't measuring fecal calprotectin. So we examined him in clinic here at the IBD clinic, and wow, we found some incredible bowel loops that were phenomenally dilated. Like, these are just remarkable with abnormal peristalsis. So this is a classic depiction of a bowel obstruction. This is the right lower quadrant. This is a complicated examination here. This is the psoas muscle, ileal vessels, and these bright little marks here, those are staples. This is the ileoclonic anastomosis. So if they're going to stricture anywhere, it's here. And what's interesting is we can see maybe a very, very narrowed area there. And you can start to see fluid being filled in the proximal small bowel. So he also had a CT scan because he wasn't doing well, and it really wasn't very helpful. It didn't provide us any more information. I think the suggestion there was maybe he has gastroenteritis. So we weren't too suspicious of gastroenteritis. So we scoped him, and this is what we found. So this was about a 2 millimeter diameter, very cold stricture that happened acutely postoperatively, which is something that we see uncommonly, but again is the explanation of his obstruction. So the second big group of complications we see are those that are the result of deep ulceration or holes in the wall of the bowel or penetrating complications. This is an example of a remarkable young woman. This is very black bowel, very, very inflamed, coming to a huge left lower quadrant abscess. So we're actually coming from the hepatic flexure down into the left lower quadrant here. You can see the white area around this very black hypoechoic bowel, and it's coming down, and you can see some of the black spicules coming off the wall of the bowel, and then air outside the wall of the bowel. So this is a very good example of very sick inflamed bowel, and then a left lower quadrant abscess that is secondary to the severe disease. And what's really important here is when you see those almost like small little finger-like projections coming off, that's fluid and pus. And this is an example where contrast enhancement, which we perform in Calgary, can be helpful to determine whether or not there's drainable pus in there. So a phlegmon or inflammatory mass, this is this ear-like loop in axial depiction of bowel. And here you see an inflammatory mass, and these little guys here are very important to pick up. That's air, as you well know. So this is with lots of surrounding hypertrophic mesenteric inflammatory fat, little bits of free fluid, and here you see air outside the wall of the bowel. So this is a perforation on a small abscess. We do see fistula tracts. This is an image again from Dr. Stephanie Wilson. Again, mesenteric hypertrophic inflammatory fat. This is an axial loop, and this is a tract that goes into another more proximal loop of small bowel above it. Again, I mentioned contrast enhancement, which is a contrast agent that actually stays intravascular. These are all Dr. Wilson's beautiful images. I do not perform contrast in my clinic. It's difficult to do in a point of care type of context. These are the vessels that are so beautifully highlighted here. Again, you can put a region of interest marker on the wall of the bowel and quantify the peak enhancement that reflects inflammatory burden. Let's move on to a third case. This is an interesting one. You've actually already seen this one of these images. This is a young mom who had long-standing ulcerative colitis and actually was being controlled with biologic therapy. But the two of us had kind of come to a decision to say, you know, this has been going on a long time. You're refractory to medications. we'll arrange an elective subtotal colectomy. So she was actually going to have surgery. Unfortunately, she had quite a change in her normal status, which was with less frequency, more distension, more discomfort. She went to a rural emergency department, and they were concerned, she was on an immunosuppressant, that maybe this is a urinary tract infection, had a couple urinalyses, and they were bland. And they knew that she was following up with me, so there really wasn't a lot more investigation done. Where are her pictures? Okay, I don't know why they're not there. So basically what that showed was thickening of the wall of the bowel that was quite mild, and the picture that you saw of the perforated appendix. So she had the cap of fat and then the very small perforated appendix. So the reason why I wanted to bring this to our attention is because we always sort of sometimes have to be careful not to get into a frame of thinking for causes of certain things, that you can always be challenged by things that happen, complications that occur that may not be typical of what you're expecting, and may be outside of that, but we always have to think of common complications that occur even in inflammatory bowel disease. So she had a perforated appendix and came into hospital for intravenous antibiotics. So the second big group of diseases that we do see, ulcerative colitis, we've just demonstrated a case of. There are some classic features of ulcerative colitis on imaging. Because ulcerative colitis from a GI perspective is often thought of as just affecting the inner lining of the bowel or the colon, the mucosa, which is, I think, a falsehood. We tend to just scope these patients and not image them as much. So I think that our understanding and characterization of UC is somewhat limited. We know from plain films that you see lead pipe features and chronically inflamed UC, and you can see this just beautifully on ultrasound. So this is a gentleman that was actually diagnosed with UC in 2011, was lost to follow up, and presented last year with active UC. And here you see in longitudinal format or depiction the very straight colon with absence of haustra. You can see some fat as we move on and off the colon. So inflammatory mesenteric fat is slightly present, maybe not as bright as we see with Crohn's disease, but there are some changes. The echostratification is normal, and the remarkable entity is the total absence of haustra or normal folding, in addition to the thickened wall of the bowel. And this is his endoscopic examination, which demonstrates active ulcerative colitis that was going on for many, many years. So we've talked about two diseases. We've talked about inflammatory parameters. We've talked about complications. The third and incredibly important utility we use point of care ultrasound for in our clinic is to evaluate whether or not the drugs we're using work. So here's an example in longitudinal depiction of thickened bowel. And here again in axial depiction, nice normal echostratification. And here you can see marked change of the wall where it's really gone to normal. So if we can follow patients over time and measure their bowel wall thickening as well as other parameters, we can really see quite a robust response to therapy. We know based on a previous study that I did with colleagues in Germany, that where they use intestinal ultrasound on a regular basis, both in emerge, internists perform intestinal ultrasound, surgeons perform intestinal ultrasound. It's a widely used application that when used in clinic, it changes decisions for cases in significant numbers of cases. In our short review of 50 cases, it changed those decisions about 60% of the time. So it's an important adjunct to care. This gentleman highlights how these clinical decisions can be facilitated by ultrasound performed in clinic. This young gentleman, 24-year-old non-smoker, presented acutely, again, one of those folks that presented with Crohn's disease, new diagnosis, but complications. He was admitted to hospital with abdominal pain, and he had a short segment, 5 to 8 centimeters of terminal ileitis, documented on a CT scan done in the ER, and there was some suggestion of narrowing. So in hospital, very importantly, there was no suggestion that he had any penetrating complications. And because this was his first time presenting, we thought let's see if we can improve things with use of corticosteroids. So he was placed on corticosteroids. He got remarkably better. His blood work looks fantastic. He's not iron deficient. He was sent home with follow-up. So this is his ultrasound, and we performed these every 2 weeks while he was an outpatient. This little guy down here is his appendix, and you can see the beginnings of a fistula. And this is increasing obstruction with demonstration of proximal dilatation, absence of echostratification, and you can see those black hair-like fingers coming off the wall of the bowel, suggestive of imminent, if not presence of penetrating complications, and again, a fistula to his appendix. So this is severe disease that actually progressed while he was an outpatient, and ultimately we scanned him and saw some air outside the wall of the bowel and sent him for an operation as opposed to putting him on a biologic, so it was very helpful. And he wasn't unwell, so this is something that he could have waited and then developed a significant abscess for had we not been able to very closely monitor him with intestinal ultrasound. So this next case was provided to me by my good friend, Dr. Stephanie Wilson, and these are her beautiful images. And this is an example of where we always have to think outside the box, particularly as IBD doctors. This 76-year-old man had some epigastric abdominal pain, and he actually went to an outpatient clinic, and they saw a darker centrally located hypoechoic lesion, thought to probably be a transverse colon cancer. So he had a colonoscopy performed as an outpatient, and it was completely normal. So they sent it to Dr. Wilson, who's an internationally recognized expert, and this is what she found in the right lower quadrant. So this is proximal small bowel. So just really interesting when you think about some of the images that you've seen, you can understand why you would see this and say, wow, I wonder if that's Crohn's disease. At his age, that would certainly be interesting, but maybe this was, and he was having pain, but you know, the presentation was fairly benign. So again, we think about the serosal edge and the smoothness of the edge, looking for those spiculation. This is kind of an odd pattern of echostratification. And here is the lumen. So it's also, it's quite asymmetric. So here again, instead of seeing what we would see in Crohn's disease, which is luminal apposition, which is classically stricturing, progressive stricturing disease, you almost see a small dilatation here in this very short segment, hypoechoic echostratification that's disrupted, small loop of proximal small bowel. So again, a little bit atypical. And I draw your attention to these kind of funny looking things. This is quite atypical. I don't know that I can even explain it, but the serosa looks disrupted. Here is the color Doppler imaging. And again, a little bit of strange dilatation in the middle of the lesion, very hypoechoic walls. And if this was hot, untreated Crohn's disease, I certainly would expect this to light up like a Christmas tree, which it really isn't. Here is a short clip, again, from Dr. Wilson. She's phenomenally skilled. And this demonstrates, again, this very short segment of this very odd lesion. So this turned out to be lymphoma. So the other thing that you can often see is sort of a mass of loops and lymph nodes that can all conglomerate together and can be quite tricky to discern from something like Crohn's disease, particularly if the patient is young. So this is a great example of where if you take a systematic approach when you see abnormal bowel and you go step by step thinking about inflammation versus other causes of wall disruption, you can try to come to a rated differential diagnosis for further evaluation. This is his CT scan, this is right lower quadrant, and this is the mass here in his right lower quadrant. So I'm going to wrap up very briefly. I don't want to miss the fact that irritable bowel syndrome is where our business often lies. The vast majority of patients who a general gastroenterologist would see in clinic is a symptomatic patient without any significant organic detectable disease, but has significant impairment of quality of life. And I believe that a combination of use of simple stool tests like fecal calprotectin and intestinal ultrasound can be incredibly reassuring to the patient and demonstrate normalcy and potentially even obviate the need for an endoscopic examination when their blood work is normal, their fecal calprotectin is normal, and their intestinal ultrasound is normal. So these are just images, again, throughout the abdomen of normal bowel. And we know that in a small series we published that was prospectively evaluated, that the sensitivity and specificity is quite good. And this is without combining it with other parameters like CRP or fecal calprotectin. So this is a use that we employ in Calgary often to try to minimize the need for endoscopic examination. Ultrasound isn't perfect for sure, but it has a lot of incredible merits, and I've gone over some of those in detail. It's highly effective, it's safe, it's tolerable. Patients just love it because it's engaging. They can understand what's going on and seek immense reassurance. In real time, we can see the gut moving. I don't know in my whole training that I ever really talked to anybody about, despite being a gastroenterologist, about how is the gut moving. I think this is one of the most important things that we can appreciate about the intestine. There's lots of evidence to support its utility, it's inexpensive, and it's highly repeatable. Now, we have established with a European Crohn's and Colitis organization an internationally recognized curriculum, and we've now trained or engaged with people who are interested in training folks from over 31 countries. So it's spreading like mad. It's coming to the United States, but certainly the number of trainees in the United States are not quite as plentiful. So I'm going to work on them for sure. I know that they'll come. We've had a few come to Calgary for training, one from Tennessee and one from Los Angeles, which was amazing. In Canada, we now have 9 centers, and it's growing like crazy, particularly for pediatrics. There are limitations, as you all well know. This is a moving organ. It can be tough. There's a bit of a learning curve. We are working on a paper right now to try to evaluate that learning curve. The anatomic resolution is tough. It's not like looking at an MR or a CT in coronal section where you can depict all the location of the anatomy. We need to speak the same language and standardize our measures. It can take time, particularly when patients have complex disease or they've had surgery. And sometimes abdominal adiposity can preclude adequate measurement or evaluation, but often it doesn't. So you have to try it in order to determine it. I can't speak without acknowledging my good friend Stephanie, because I wouldn't be doing this if not for her. And I think the other part about this is the collaboration with radiology. We have a wonderful collaboration, and I'm grateful for that because we can work together to try to care for patients in the most thoughtful way. So I'm grateful for your attention, and I welcome any questions.
And do you see questions, Dr. Novak, or would you like me to read them for you?
I have to open my chat box. I would like you to read them for me.
Or there should be a question box, but yes, let me get back up here to the top. We have a couple. Okay, here we go. Do most of your symptomatic patients have focal or diffuse pain? Also, what helpful strategies could you give us to get started with bowel ultrasound?
So the first part, Darcy, just for clarification, I guess I'll say lots of our patients actually have no pain despite the fact that they have active disease. And then there's patients who have lots of pain and they have no disease at all. So there's a huge range. And I think what's wonderful about localized pain is that you can use the ultrasound as a tool or a guide to try to help understand why that pain is coming from there. And it can be tricky. So for example, just a quick example, sometimes we see patients with a right lower quadrant stricture. So they have a terminal ileal stricture and they have pain in their left upper quadrant. And the pain is because their small bowel is dilated and it's stretching and it's causing pain. So when you look in the left upper quadrant, you see those dilated loops. You can say to the patient, this is why you feel pain there. So it's a very engaging piece. Certainly when we find nothing, it's difficult when patients have pain because pain, as you know, is very complex. The second example is that I would suggest starting in a systematic way in either the right or the left lower quadrant and try to identify the structures that you know and go from there. And compare it to imaging that you can interpret. So CT scans are so beautiful with great resolution. And so look at your images and then compare them to CT. And that is just a wonderful way to learn.
Thank you. So here is a second question. How well can you see echo stratification with a 5-1 megahertz probe versus the 9.2 that you showed in the presentation?
Yes, great question, not that well. So in bowel ultrasound in particular, there are two uses for the 5-1. Number one is to look at the rectum because it has that penetration that can evaluate the rectum, as I said earlier. The second is if you need to map the disease. So sometimes what we see in my world is loops of bowel that can be tethered, and you need a bigger kind of depiction of the abdomen. So I don't spend time as a non-radiologist looking at anything but the bowel, and I consent patients that way, which I'm sure is obvious. I tell them this is a focused examination. If I have to understand the anatomy and try to kind of figure out things, then I use the 5-1. If I'm trying to characterize the wall, then I use the higher frequency probe. Even the linear sort of 12-4 probe with the higher frequency, if the patient's thin enough, you just wouldn't believe the resolution. So it's the compromises resolution. 5-1 just doesn't have the resolution to adequately look at the wall.
Okay. So how to differentiate the rectum from sigmoid colon in transvaginal ultrasound? Is there a border ultrasound marker?
So I will say I don't perform transvag ultrasound. We don't have that capacity in our clinic. So what we do is we do transperineal ultrasound, and we just do transabdominal. So, you know, I will say for folks who are quite used to looking transvaginally that the colon and the small bowel are distinct organs. They're very distinct. You just know small bowel when you see it versus colon. The colon doesn't move. The colon has different characteristic features, and generally the small bowel deep in the pelvis is not going to have a stool pattern. It can have a fluid pattern, but it's not going to have a stool pattern. So I would say there's a number of features which I would be happy to communicate directly with the person asking the question, because they are very distinct organs, and you can easily tell the two apart.
Excellent. All right. This next question's a little challenging. Do you see patients this ileus? Do you find ultrasound helpful in distinguishing ileus from SBO?
So you know, it is a good question. I think that I would break it down sort of into a couple of parts. Number one, if you suspect that the patient is obstructed, you can document this very clearly on ultrasound. So the first question is the patient obstructed? So that's question number one. Checkbox yes, very easily. Checkbox two is what is the cause of the obstruction? There is definitely a process that you would go through systematically evaluating the 4 quadrants of the bowel to determine that. So what we can see is where bowel is collapsed and where bowel is dilated in the bowel, in the abdomen, sorry, so that you can make an estimation of where there is an area that is causing the obstruction. So an ileus may be causing symptoms of obstruction, and so you can determine that by looking at bowel movement and the wall and areas of overt collapse, if that makes sense. Because, you know, let's say the obstruction is in the proximal ileum, you should see collapse of the distal terminal ileum. If it's just an ileus, then you should see fluid and contents with dysmotility of the small bowel. So I think you can see it. I don't see a lot of patients with ileus, but I think if you approach it in a systematic way, you could.
All right. When you first started doing bowel ultrasound, when did you know to order further cross-sectional imaging like CT or MRI?
Yeah, excellent question. So I'll try not to be lengthy. So I started to observe intestinal ultrasound in 2009 when I started my career, and I went to Dr. Wilson's unit and I watched for 3 years and started to do research with her. And then I went to Europe to train, and then came back, and I kind of come back and forth with Dr. Wilson. So that's a very quick synopsis of my training. When I started out, I did a adjunctive gold standard with every scan I did to ensure that I wasn't missing things. I think the biggest thing is to be humble and cautious and know your limits. So now when I'm making decisions, it has to do with the degree of confidence I have with the images and the findings and the consequences if I'm wrong. So for example, when we start patients on immunosuppressive therapy that could lead to significant infection and illness, and I can't see the deep loops of bowel in the pelvis sufficiently to say there's no penetrating complications, then I correlate it with an MRE or an ultrasound performed by my friends in radiology. So I think that it's a bit of a learning curve. In the earlier stages, you tend to compare it more often, and I avoid CT when I can. We use CT in Calgary mostly for urgent issues, ER presentations, or ones where you just need better resolution. And we have longer waits for MR, but the correlation is important depending on your confidence. And that confidence has to be matched with the consequences of being wrong.
Okay, do you have time for one more question?
Of course I do.
Okay, and this is going to challenge my vocabulary. Bidirectional movement of intestinal content on ultrasound, is it always abnormal?
So it's such a good question. So I have thought that some of my patients were obstructed when they had just been to Tim Hortons and had 4 liters of coffee. So I would say no, and I would say 2 things, 2 important things. We need a systematic and evidence-based approach to evaluation of motility, and we don't have that. I don't think there's a single publication on motility, which is obviously subjective, but we need a systematic way of looking at it in the fed state and in the fasting state so that we understand the spectrum of motility. We're just starting to understand that. The second thing is it also depends on the history and the anatomy of the patient and whether or not you have concomitant disease, activity, or other things going on. Certainly in small bowel loops where patients are in fed states, it's not always sonographically demonstrated as propulsive. So you can see some swirling of the contents. But if there's dilatation with that, then I certainly look at that as potentially non-propulsive. So I don't know that it's a very good answer because I think we need more evidence and we need more evaluation of motility. But I think that it's a composite assessment where you look at the whole picture and decide whether or not that patient has abnormal peristalsis.
Wonderful. Well, thank you so much, Dr. Novak. Our hour is up. On behalf of the AIUM, the ACP, and SUSME, our thanks to all of you who participated in today's webinar. We hope you enjoyed the presentation and will join us again in the future.
Thank you so much.
Bye-bye.
Have a great day.